that the trauma service in UK needed to be consolidated. And then there were further reports that showed that 60% of major trauma patients received a standard of care that was less than good practice. So that's not great reading, is it? And then there were compelling arguments for saving lives by creating specialized centers for major trauma. So that came out in 2008, just about when I was finishing my training. And then the solution for this was to create a trauma network for the whole of UK with major trauma centers across the country and local network of trauma units with a robust data collection through the Trauma Audit and Research Network. The reason for doing a major trauma center was because it had been shown that specialist trauma centers reduce mortality by 25% and also length of stay. They also reduce death by a significant number, as you can see. And the key was that the time from injury to definitive surgery is the main determinant of the outcome in major trauma. It's not the time to arrival in the nearest emergency department. So you've got to get to the right place quickly, not just any place. And the other important thing is that major trauma patients that are managed initially in local hospitals are up to 5 times more likely to die compared to the ones that are transported directly to a trauma center. So these kind of gave the impetus to develop the major trauma centers. But of course, there were challenges, and the challenges were based on the fact that this was the first integrated countrywide trauma network in the world. This was not done anywhere else. So there was nothing to learn from. So you have to start
recording
a
in
pilot
progress
in London in 2010, which is when I became a consultant. And the idea was that there were going to be 4 major trauma centers in London. Each would have its own trauma network. And these were the 4 major trauma centers. Was in the 4 geographical corners of London: North, South, East, and West. I work at Imperial College St. Mary's Hospital. And then these were covered by regional trauma units, which would then be part of the regional trauma network. And then the London Ambulance Service were told that this is what's going to happen, and they were given a new way of triaging patients and bringing them to the trauma centers. So if you look at the picture, so these are the 4 major trauma centers. This is a map of London. These are the 4 major trauma centers, the big stars. And then you've got these smaller hospitals, which are called the trauma units. And each of these star with this trauma units form the trauma network. So what is a major trauma center? Essentially, we define major trauma center as a fully staffed accident emergency department 24/7 with a consultant-led resuscitative trauma team, dedicated trauma theaters, and presence of all the major surgical specialties in a single site. So there was no question of having to move patients around when they came to these trauma centers. And what was encouraging is when you first we did an analysis of the London trauma network, we found that the patients were being sent to the major trauma centers a lot quicker than we had thought they would be. So it was good. And we were seeing, only 0.1% of the A&E cases. So there wasn't a huge increase in the workload. And we found that the commonest head injury causes of injuries were road traffic accidents, and commonest type of injuries were head injuries. And only 32% of the cases that we defined as major trauma were turning out to be ISS greater than 15. But the key was this, that in the first year, it was analyzed that an additional 58 lives had been saved just because of the London trauma network. And if you look at the survival statistics over the next 10 years, you can see that this is the odds ratio. So this is a survival statistics when there was no trauma center, and this was a likelihood of survival. And then the trauma system was initiated in around 2011. And then you can see a consistent improvement in the survival statistics, which is obviously very reassuring because it kind of proves what we had thought always was going to be the case. So looking at the current major trauma centers in England, these are the red dots are the major trauma centers. There's 22 of them across the country. And they all link into their own trauma networks. So So that's kind of where we are at the minute. There's a lot of data still being collected to see what implications these trauma centers and trauma networks are having, and up to now it's been quite positive. So that's the improvement and update in the systems process for major trauma. Standard routine ankle fracture, you have the x-rays and you have the fixation of the fractures, right? So there's no problem there. But what happens sometimes, then we all know this because we've all been faced with this, is you end up getting this. So you can either have infection, you can have long scars, and you can sometimes have metalwork failure. So this is the traditional way of treating ankle fractures, and this is what still happens in a majority of places nowadays. So the question is, could we make this better? Could we do something that would reduce the scar size, maybe reduce the chance of infection? So the development that came through in the last 10 years or so is through the use of percutaneous or minimally invasive techniques of treating ankle fractures. And we use something that some of you may have already come across, and it's called the fibular nail or fibular rod, which was designed sort of around the 2007-8, went through several places nowadays, changes and modifications. So the question is, could we make this better? Could we do something that would, and this allows us the scar size, these common fractures with small percutaneous cuts, thereby reducing the chances of infection and reducing the chances of long scars. And actually, when they have been tested biomechanically, you can see that the red line, which is the line for the fibular nail, is much stronger and can withstand much stronger forces compared to the traditional plates, which is the black line below. So mechanically, they are quite strong. Common fractures. The implant is a tapered titanium implant, as you can see on the right, with 2 distal interlocking screw holes, 2 syndesmotic screw holes, and it's available in 2 diameters and in 3 lengths. And the idea is you make a small cut, you pass a handheld reamer through, and then you ream over the guide wire that is passed through, and then you put the nail through the jig, and then you can lock through the jig. So it's relatively straightforward as long as you can get the entry point correct, and it allows you to reduce the fracture. Sometimes if the fracture is not reducible, you can make 2 other small percutaneous holes and use a pointed reduction clamp to reduce the fracture and then pass the nail through. And here you can see me putting a nail through. So that's the hand reamer that is being put through, which will be followed by the nail. And you get, that's the picture coming through. And then you can pass the screws through the jig. And hopefully at the end of it all, you could just put some steri-strips, and that's the kind of skin condition that you would get. And you can see that these heal quite well as well. So the advantages are there's less soft tissue complications in the early stages. And this is very good for especially elderly patients, diabetic patients, patients with neuropathy, and patients who come in with big blisters around their wound. You don't want to put a big scar around the blisters. It also avoids late skin and metalwork related complications because there's no prominence of the metalwork. And therefore, removal of the plates and screws is not required, and it gives a much improved mechanical stability. There are lots of papers looking at this with good results. It was initially developed in Edinburgh, so you can see the papers from Edinburgh, and then we published our results from a level 1 major trauma center, looking at these nails, which were quite good in terms of results. So let's now look at the next update, if you like, on trauma techniques. So this is again a standard fracture, which I'm sure all of you deal with in your daily professional life and deal with very well. But why do we need to do anything new here? So this is what you normally do. You, in various figure 4 positions or in this position, you start put a nail down this big fracture, and it heals and it works well. So that there is no controversy in that. So why are we planning to change or do anything different? It's because you sometimes get these kind of situations, and you can see here very well that the fracture has been malreduced, or in fact, the entry of the nail has caused the fracture to become worse. And the reason for that is when you have a very proximal tibial fracture, like you had in this particular case, you have got a large volume in the metaphysis, which allows deformity during and after the nailing insertion. The other problem is when you're positioning the leg with the leg bent in over a bolster or whatever, there's a lot of deforming forces that you can see coming that tends to pull the proximal fragment up and brings it into procuratum. And then also if you've got a compression behind the popliteal fossa, that can cause swelling of the leg compartment syndrome, etc. So is there a way of dealing with these multiple problems? This is another way of, this is another of those problems. So you can see again, it's a proximal fracture. You've got the patella. I've drawn the patella with the red circle. And you can see the patella is stopping a good reduction and a good entry point of your nail. And as a result, if you put the nail in that way, you are going to get that deformity because the nail has gone into the valgus side. And as you try to straighten the nail, it causes more valgus of the fracture. And similarly here, the nail hits the back. And as you try to go in, it causes a procuratum. So that's the problem with doing the standard approach. So for all these multiple problems, we have a slightly newer solution. It's called the suprapatellar nailing system. It's not as new as people think, but it's been there on for a good 10, 15 years. I was lucky to do one of the first ones in London when they first brought in, and immediately fell in love with it. And I've never done a nail since then without the suprapatellar approach. And essentially what it means, it goes underneath the kneecap, as you can see, using some special equipment. Not hugely special, I have to say. Sometimes if you don't have any of these long trocars, you can even make it out of a syringe. And all companies now have come up with these trocars. The key here is you can have the leg straight with just a sandbag underneath the buttock. You need to just elevate the leg a bit to give you access to fluoroscopy and just a little bit of flexion in the knee. So this is how I do my suprapatellar nailing. And then you make a small incision, and you can see that here's the trocar that's gone behind the patella. And because the leg is straight, there's no deforming forces of the muscles. So the fracture usually stays very well reduced. And then you can put the nail through without problem. The advantages are the position is extended. So as I said, there's no deforming forces. There's a much better entry point for the proximal fractures. There's no moving of the extremity, and there's no pressure on the popliteal fossa. And because we are not making a big scar in the front of the knee, the idea is that it might help to eliminate some of the anterior knee pain that we see in 50% of infrapatellar nailings. The disadvantage is that sometimes you can have stiffness in the patella, and this is the perceived disadvantage. To be honest, these are not disadvantages that have been proven. These are what people think can happen, that the patella can become stiff, the joint can get infected, you can have damage to the retropatellar cartilage and other internal structures in the knee, and you can leave some debris within the joint. And actually, if you look at the literature, all of these have been looked at, and they have not been proven to be true. Once again, we actually published a lot of these tibial nailing with the suprapatellar approach papers look at 1 year results, which are all good, because we started our suprapatellar nailing a long time ago. I was able to publish the first median term outcomes about 5 years or so. And even in there, we found no difference. And in fact, there was an improvement in the anterior knee pain. So it's definitely a technique that I've fully taken on. And as I said, I've never done an infrapatellar nailing in the last 10, 12 years. And actually, if you get good at it, you can do some really fancy stuff with it. This is not my own case, but it's just an example of what can be done. These are cases which we always struggle with, but with the suprapatellar approach, look, you can actually go in front of the implant and get a very good reduction. So that's sort of one of the other techniques. And then here's another technology advantage that has come through. So we have always been doing distal locking of our nails using fluoroscopy and the perfect circle, and we're trying to turn the x-rays round, back, front, shouting at the radiographers, all kinds of stuff. It causes excessive radiation because you have to take so many pictures. It's time consuming. It's difficult to get that perfect circle, and unless you have a radiographer who knows what they are doing, it's a real pain. You have to drill holes, and sometimes it can damage implants because you're not in the right place. Jigs have been tried previously, but the long jigs don't tend to stay as much rigid, and therefore they always miss the hole. So is there an answer to that problem? And of course there is. And this is a technique and a device to do free locking, extra free locking of IM nails. And you can see there's this steering wheel type instrument, and you got this screen, and you got these circles. And what happens essentially is, as you can see here, once you have put the nail in, you actually put a very fine rod that goes on the inside of the nail, which has a laser marker, and that gives you a picture here. And then the steering wheel-like structure here has a probe that then points to the laser marker. And all you need to do is you need to align the red, the green, and the gray circles together, and you can fire it through, and it will always go in. It causes a lot less radiation, and that's been proven through some of the papers as well. So that's another way of technology helping us. If you do major trauma, you can sometimes get these kind of big injuries with big bone loss, and you always wonder how do you fill up these gaps. And traditionally you can use allografts. Getting autograft of this volume can be quite difficult. But again, we use masculine techniques where we put cement initially, let them form a membrane, and then fill it up. But the question is, how do you fill it up? So you can see here, the cement was initially put in. That allows a membrane to be formed around the bone. You take the cement out, and then you fill it up with graft. But the question is, how do you get the graft? And if you get enough graft, then obviously it heals well. But as I say, it can be quite difficult getting that volume of graft from somewhere. So therefore, another new technology that's come through, some of you may already have seen it, maybe all of you have seen it. This is called the RIA, or the reamer, irrigator, and aspirator. This simultaneously reams and aspirates, so you can collect a huge amount of bone graft from long bones. It should be used as a single pass of the femoral canal. You can't do too many passes, otherwise you can fracture the femoral canal. You got to keep irrigating it to prevent thermal necrosis of the canal. And the aspiration reduces intramedullary pressure and the systemic effects of the reaming. And of course, much shorter surgical time because you've got a lot of reaming coming through from there. And actually, if you look at it, there are lots of advantages to this. You get a large volume of autologous graft, so it's not donor graft, not allograft. Therefore, there's no donor site pain or morbidity. It's potentially much more biologically active, and it reduces all the risks of a bone graft harvest, like injury to lateral femoral cutaneous nerve or avulsion fractures, etc. Of course, there are disadvantages. It's aggressive, and sometimes if you have done too much, then you might even have to put a nail down the leg. And thankfully, it doesn't happen very often. You just have to be careful and do a single pass. It's obviously not very suitable for osteoporotic bones because it can then fracture or the curved intramedullary canals because the reamer is quite stiff and straight. Small are not suitable, and you can have blood loss, and sometimes the driver shaft can break. So those are issues that you have to be aware of. But this is a setup that you can see, and you basically measure the width of the canal, and then take the correct reamer, and then you collect the bone graft just passing the reamer like that. through the femoral canal, and you can see you can actually get a huge amount of bone, and then you can use that to fill up your defect. Once again, there's lots of papers on this which have shown good effects. So that's kind of, technology, that's where it's leading to. I'll finish off with one other thing. So this is, probably a slightly more higher end. And I'm just going to show you a case to demonstrate the current technology that we can use for our trauma. So here is a patient who had a fracture of a tibial plateau, nothing major, and this was fixed, but unfortunately it wasn't fixed very well. And after the fixation, she had a lot of problems. And if I just play this video, hopefully you'll be able to see how she walks and her deformity. So you can see very clearly that she's not able to walk very well in a straight line. And she was seen at another place, and she underwent examination under anesthesia to try, and people thought that her ligaments were not working and thought there was an MCL insufficiency causing the valgus, but actually that wasn't the case. And if you look very carefully through a CT scan, what you can see is she had a reverse slope created after fixation of that fracture, and that was obviously causing the femur to dip into the tibia when she was walking. So I'm very lucky because I've got a very good team of engineers that work with me at Imperial College for these kind of complex cases. And I gave them her CT scans, and they created a model where they showed me that this is the current state. And we kind of did some computational analysis and decided that this needed to be the final state if we were going to create a corrective osteotomy. So this is the pre-correction deformity. And the idea is we want to make those cuts and create this plateau change to reverse the slope. So going from there to there, but obviously that's not going to be easy, and it needs to be very precise. And so what we decided is the only way to get, because it had to be a biplanar osteotomy, because it was not only correcting the anteroposterior, the sagittal plane, but it was also correcting a bit of the coronal plane. So we decided to do a biplanar osteotomy. And the cut was going to bring out a sliver of bone of that shape. And this was all done through computers and through the engineers. And I said, I can't be that precise. How do I do this? So they created a jig for me, so a pattern of the jig. So they created a system where these little plates would sit on the malleoli, and those are fixed points. And then everything would be modular and built on them. And then these little holes would have guide wires, so it'll fix everything. And then the slots would allow me to pass a saw through and make the cut. So quite clever stuff. And they even created a guide for me, an idiot's guide to corrective osteotomy, I suppose. And this is what we were looking to do. And then we have this 3D printer. So all the jigs that we had designed were printed on this 3D printer. And you can see these are the jigs that were given to me. And we created this sort of modular jig, starting from the ankle, building all the way up. And then I placed the jig on the leg. We fixed them with the guide wires. And then I passed my saw through the slots that had been created to give me the absolutely accurate correction that I desired. And then after the check X's were done, you can now see that the slope has been reversed. So this is quite a good use of technology to help you with your procedure. And then if you see her walking now, that's her. Obviously, it's not absolutely perfect, but you can see the difference in her walking gait. So that's, I think, sort of the higher end of technology being used for trauma purposes. I've talked a lot. I hope that was helpful. I'm going to stop now because that's the end of my presentation, and I will take any questions if anybody has.
Thank you so much, sir, for this very nice presentation. Thank you so much, sir. Dr. Srinivas.
Thank you very much, Raj. That was, thank you very much for the excellent talk on all the fantastic recent developments in trauma. The future of trauma is very exciting. even with the changes in AI coming in. I think, do you have any applications for AI in trauma in the future?
So I think there is. So we are already starting to use AI in mainly developing, the fracture patterns. That is one thing. So pelvic fractures and complex tibial fractures, we are starting to recreate those using AI. The other thing, the exciting thing that I'm quite heavily involved in is technology, so that we can use fluoroscopic images inside the theaters and use them to create real HoloLens based 3D images in front of you as you're operating. So rather than having to use CT scans, MRI scans, you take fluoroscopy images, and those will create 3D images of the fragments. And then as you're recreating and putting them together, you can have a much better spatial orientation. So that's quite an exciting project, converting 2D images into 3D holograms. That's going to take a bit of time, but we're getting there. The first couple of steps have been taken, and some of the work has been done using neurosurgery. And the next step is to move into orthopedics. So those are the two immediate things that come to mind for me.
Do you use 3D printed bone graft for bone gap filling?
We haven't. So I don't have personal experience of 3D printed bone graft, but I know some places do.
Okay. And what are the implications of major trauma centers on training on trainees, for trauma, as well as the trauma consultants in the peripheries?
So I think that's a very good question, and that tension has been there initially. It's starting to get a bit better because of the major trauma centers. All the complex cases, and even some of the sort of polytrauma with simple cases, are coming to the major trauma centers. So the district general hospital consultants are getting a bit more de-skilled, if you like. And so if you're a trainee in those hospitals, you don't get to do as much as we did in our times. But actually, London is a bit unique, because London has got a lot of hospitals in a very small population area, and that's why the time I showed you, the 16 minutes to major trauma center, is quite unique in London. If you look around the country, the major trauma centers are quite spaced out. So if you say, for example, you've got a major trauma center in Oxford, the nearest trauma unit to Oxford is about an hour away. So if there is an injury near that trauma unit, unless it is an ISS greater than 15, the ambulance isn't going to bring that patient all the way into Oxford. They will take it to the trauma unit. So the idea is the trauma units will do the bread and butter stuff. So the long bone nailing, the wrists and the ankles, but they won't be doing the open fractures that require plastics input. They won't be doing the polytrauma that require pelvic surgeons and all of that. So therefore, the idea is all trainees must spend at least a good year or two at major trauma centers to be able to see those complex traumas. So that was initially an issue, but now it's been resolved much more by making sure that all trainees get a placement in major trauma center during their career. And in terms of consultants, there will be surgeons who want to do trauma as a career, so they have to look for jobs in major trauma center. There are other surgeons who are happy to do just the ankles and the wrists and want to concentrate on elective surgery. So for them, the district general hospitals are much better.
And using RIA, how much, what is the maximum volume of bone graft one can get? So
the key is, the maximum volume will depend on how big the bone is, how big the person is. The key is you can only do a single pass. So whatever you get in a single pass in one bone, you have to be satisfied with that, because otherwise you're going to fracture the bone, because you're taking away a huge chunk of, medullary cavity bone. So it varies. I mean, you saw we got about 50, 60 mils. It's a lot that you can get.
From the affected side, is it? Can you take from the other long bones as well?
Yeah, that's what I'm saying. You can take it from the other long. So if you've got a big femoral defect that you saw on one side, we use the other femur. Sometimes, if you're worried, then once you do a RIA, you stick a prophylactic nail down that other femur so that doesn't fracture. But it saves you having to have a huge amount of bone graft, and because it's biologically active, because it's autograft, the chances of healing those big bone gaps are much bigger.
Are there any applications for stem cells, in trauma management?
I'm sure there will be, but we are still on the very sort of, cusps of breakthrough. We haven't quite got there yet. So I think eventually stem cells will play a role, but I don't think they're in that phase where we can turn to them yet.
Thank you very much. Thanks.
For you, please, sir. Do you use the suprapatellar way of the suprapatellar approach in interlocking tibia routinely, or just in proximal tibial fractures and in special situations of the fractures?
Every case, as I said, in the last 12 years of my career, I've not done a single infrapatellar nail.
Yeah.
Once you get used to the suprapatellar nail, you will not want to go back because it's so much easier. I can do a nail by myself without a trainee with me because the leg is just straight. You put a sandbag underneath the buttock, keep the leg straight, and then there is no deforming force. So there's no pulling, pushing, anything required. Just put a rod down, put the reamer down, and that's it. So it's really, a very convenient way of doing it once you get used to it.
And if I use it in the proximal tibial fractures, I think there will be no need for blocking screws. Correct.
But also, if you have the blocking screw technique available, sometimes you can use it because, if you've got a very big proximal tibia, you might have to. But again, it's a lot easier. So if you say, if your wire is hitting the back, you put a medial to lateral blocking screw and put the wire. It's going to go out a lot easier than if you had the leg bent by 90 degrees on a stirrup, you see, because there's no deforming force.
Yes, sir. Thank you, sir. Dr. Srinivas, we have any other questions?
I think there is one question here, sir, from the delegates, I think. It says, thank you very much. Are these technologies for 3D printing available worldwide, for example, Egypt, Libya, or the Middle East? I think Professor El-ashhab or Professor Elzohairy could answer this on. Raj, I'm
sure you have got 3D printers in all over the world. Now they are available, pretty much anywhere. So I refuse to believe that you don't have 3D printers in Egypt.
It's not costly, sir. It's not costly.
Exactly.
We can use it in every country.
I think more than the 3D printer, I think it's the availability that I have of a team of engineers who were able to compute and analyze what exactly I needed. That's what is probably not going to be as easily available because we have a very active, you might have in your active research departments, but we have a very active research department at Imperial College, obviously. So we've got some very smart people, much smarter than me, who work here.
Yeah.
How long does it take for you to get the jig once you give it to the engineers?
So I think that the creating the jig, so this whole process took us about 6 weeks from computing. So because you need CT scans, then you need to compute it, and then make sure you're happy with it, and then print it out as a trial, and then do the final printing. So it takes about 6 weeks.
Good.
We have another question, Dr. Srinivas, about the distal blocking laser device.
Is it a single use? The question is a single use.
So the little rod that goes inside the tibia, because it's going into the human body, is a single use. Yeah. The steering wheel is not, that is sterilizable, and the drills are single use, of course, and so are the screws.
Very useful for patients, especially pregnant patients.
Absolutely.
Isn't it?
Absolutely, yes. I don't know, did you have a chance to use that, Sri, when you were?
Yeah, I did actually, on a pregnant patient, I thought.
Yeah, it's very good, very, very, very nice.
Well, I was working at St. Mary's. It was
because we were one of the first places to start that in UK as well. So was the Suprapatellar nailing. So yeah, it was good.
And of course, it's beneficial for the doctors to reduce the amount of radiation, the exposure.
Yes, absolutely.
I think we have no more questions, Dr. Srinivas.
Thank you very much. And thank
you so much, sir. Thank you so much for your presentation and for accepting our invitation. You are very welcome, sir.
Thank you.
Thank you so much. Now we shift to the other presentation. Professor Alaa Elzohairy from Suez Canal University, and he's the head of the AO chapter in Egypt. Professor Elzohairy will speak about the basic concepts of internal fixation. Dr. will share the screen of Professor Alaa. Yes, sir.
Yes.
Thank you so much for accepting our invitation, Professor.
You hear me, Professor?
Yes, sir. Yes, sir. We hear you, sir.
Yes. I am very happy to be with you in this very scientific and journalistic meetings that would input for the young and the new generation doctors to be of practical and not only theoretical knowledge about all what is needed for the trauma, not in Egypt or Middle East, but also all over the world. Today, I shall speak about the change for concepts of internal fixation, and this is very changeable. So every time we have to go for the new concepts. My name is Professor Dr. Alaa Elzohairy. I am a professor of orthopedic trauma surgery at the Suez Canal University, and I was graduated to be an AO International Trustee Committee member. The AO committee member is now reaching every part, not in Egypt and the Middle East, but all over the world. First of all, I shall speak about the learning outcome. We have to outline the principles and relate them to fracture surgery today. Second, we have to describe the importance of the soft tissues in fracture surgery because we treat the patient as one organ. We have to discuss the role of surgery in diaphyseal, metaphyseal, and articular fractures. And we have also to discuss the problem of fracture disease. Next. From very old, at 1510, Ambrosio was using what's called external fixation in the first time. This is a very primary one trial to be done very early, yes. Then came Clinton at 1860. He did clinical trial using an external fixator also. He did operation for 9 patients. 8 of them achieved union. Albin Lambert, after that, at 1886, he was the first one to be pioneer in documentation, and he used the external fixation at 1902. Then after that, George Perkins at 1892 said that most disabilities that occurs following the fracture is related to the treatment and not to the pathology. And he spoke about the fracture disease. What's the fracture disease? Prolonged immobilization and an unwell bearing result in stiffness, muscle atrophy, skin atrophy, and the circulatory dysfunction. To prevent fracture disease, you must mobilize the affected limb. So, how do you move the limb but hold the fracture? Internal fixation, of course, is the solution. To prevent a fracture disease before the AO, results of internal and external fixation were usually worse than non-operative treatment. Internal fixation was usually accompanied by prolonged immobilization, which lead to the fracture disease, as I said. Robert Dennis, after that, applied blades to fracture to obtain compression. He was the first person to use compression for fracture. He discovered the primary union could occur without callus formation. The first one to know the primary union. Then Professor Dr. Morris Muller met Professor Dennis in Brussels in 1980. Between 1980 and 50 and 1956, they performed 58 open reduction internal fixation, all of which were documented. In 1958, foundation of the AO was announced. These are the pioneers for the foundation of the AO at the first: Muller, Schneider, Valiniga, Algoer, and Walter Bandy. From the first start, they started to do workshops for internal fixation in Davos, and at the same time, they did workshops for the ORP nurses in collaboration to each other, because you know that a successful operation usually needs a successful and trained personnel. They put the original AO principles, that's anatomical reduction, rigid fixation, and the preservation of soft tissue and the early active mobilization. This was done for all the fracture, types of fracture. After that, Rodi and Algoer documented 48/7 consecutive tibial shaft fracture treated by plating. They got 98% union and 3% sepsis. Then, after that, AO techniques were adopted by all the world in the 70s, and Egypt was the first country in our area to develop these new techniques for treating fractures. And also in Glasgow, they got 30% sepsis, 20% non-union treating tibial shaft fracture by plating, because intermedullary enabling was not used at this time. St. Thomas, 20% sepsis and 20% non-union. This is a very, very high rate of failure of the guiding lines. So when we went wrong, we have to read the instructions again. Did we do the anatomical reduction? Yes. You did rigid fixation? Yes. But did you preserve the soft tissue? No. That always lead to infection and non-union. The dangers to emphasis was to emphasis on the biomechanics, as you see, and we always got from this very wide exposure for and not dealing carefully with the soft tissue. We got infection and breaking of the plates and screws and non-union and delayed union. The dangers to emphasis of the biomechanics, we got these very bad results. So we have to make evolution of AO principles, taking care of the biology preservation for the blood supply. So they have to redesign the plates, place the revitalized bone by pressure on the periosteum and underlying bone. If you reduce the footprint of the plate, you will kill less bone. New concepts favor biological healing. That was the low contact dynamic compression plate by making the undersurface of the plate by new projections like football shoes to allow the blood to go through this hollow. So don't interrupt the biology of the bone and allowing good for healing. To improve the biology also, we have to change the surgical techniques. Open reduction devitalize the bone, so we do indirect reduction is more soft tissue friendly, but in articular fracture, we have to do the open reduction. Did we need all the fractures to be reduced anatomically? No. Interarticular fractures only that need anatomical reduction to get the full range of movement after operation. But in shaft fractures, it needs the restoration of length axis, and we don't allow rotation of the normal function to be restored. Abli said that callus is like sex. It is natural. It joins two things together and require a bit of movement. That's Abli. So a little bit of movement at the fracture site will stimulate callus formation, but don't exceed the normal, very, very minimal bit of movement that will lead to delayed and non-union, but very, very small bit of movement will stimulate callus to be formed at the diaphyseal fracture. We have to get the length, alignment, and we don't accept rotation. After that, we have the new guidelines that they did functional reduction, that length, alignment, and rotation, a stable fixation, but still preservation of the blood supply and soft tissue is the third issue, and the early active mobilization. This is a very big incision. Functional reduction of the metaphyseal fractures with a relative stability using plates, and the fracture is fixed from down and up, and allow the area in between to be forming callus formation, allowing the form unit of the fracture. And the plate here, like as stability to the fracture till callus formation is formed. Also, intermedullary nails were now achieved by many, many evolutions, and the expert nails also. This will lead to functional reduction of the fracture with a relative stability using a nail, and this is fracture usually healed by callus formation. Now the evolution for the principles, they put the biology at first, as we see, minimal access surgery, that we put the plate in the plane that is submuscular but extra periosteal, through a very, very small incision to allow the plate to pass in this pathway. And this also we use the minimally invasive techniques, but this needs a very qualifying courses for the minimally invasive technique. It is very difficult, but will give you a very, very good results if you master this technique. Also, the image guided surgery is now very developed, as we shall see now. And also we use arthroscopic assisted surgery, like the upper tibial plateau fractures. We can, in the same time, using the arthroscopic assisted surgery to repair cartilage, tear of cartilage or ACL or something like that. So the preservation of the blood supply is the first issue for us and soft tissue. Also, functional reduction of the fracture, that's to get the length, alignment, and we don't accept rotation, stable fixation, and also we have to go for very active early movement. That is our main aim, that the patient returns to work very, very easy and don't take very long time in hospitals, and he can return to his work. Now, we developed, we have got the new image inside the operation, that is the 3D CT imaging inside the operating room. Not only the normal image or CT image, but also the 3D. Now this apparatus was used in operating room. It doesn't need to adapt to our technology. Simply, the OR integrates your existing surgical environment. This apparatus will give us 2D imaging for localizing real-time anatomical updates and verification. Also can give us 3D imaging, that's axial, coronal, sagittal, and oblique slice data, give you an expanded view of your patient's anatomy inside the operating room. Also, it's used as a confirmation. You can view your patient's image data while they are still on the surgical table. Be assured that your surgical goals are met. Also, can be used as 3D navigation. That's the OR system together. We provide seamless solutions for surgical imaging and navigation system. Also, can give you an automatic registration of all your operations and for documentation that's we use the pre-operative planning and also during this operation and also post-operative registration and confirmation of your system. This also is very relaxable procedure, can be used in any direction and not of very big sizes to be used inside the operating room, and this will facilitate and make a revolution of our techniques in all operating the surgical techniques that will give us the very good results. This image is now available in all new universities, hospitals, but this apparatus is used by the neurosurgeon more than the orthopedic surgeons, and now we use these operations by this apparatus in the orthopedic techniques. This apparatus changes the philosophy of many classifications of fractures, like the proximal tibial fractures. Professor Shyam now changed his opinion and was sorry for his classification, and now he developed the column theory, and he has now a new book for classification of the proximal tibial fractures to the valgus and the varus type and the posterior type. Thank you for joining me in this lecture, and I hope that I give a brief idea about the changing concepts for internal fixation. And thank you, Professor El-ashhab, for this invitation, and our dear colleagues from India and from UK, and see you in Egypt in our Congress in November. That's the EOA, the Egyptian Orthopedic Association Congress, will be held in correspondence with Sekut, that will be held in November in Cairo, Egypt. Will you come all to come to Egypt and enjoy with us this very fruitful meeting? Thank you.
Thank you so much, Professor Alaa Elzohairy, for this elegant presentation about the changes of the concept of internal fixation of fractures. First of all, sir, I have a question to you, sir, regarding the changes of the concept of internal fixation. First, we have the anatomical reduction, stable internal fixation. Now we are looking for more and more respect of the biology surrounding the fractures and the soft tissue preservations. But for our young trainees, we have to have the border between the how to obtain. Many of our young surgeons think that if I have to do minimally invasive internal fixation, I don't have to have an accurate reduction. What's the border between making preservation of the blood supply and in the same time I have to respect the reduction of the fracture? They do not respect the reduction. They are saying if I don't have a reduction, that's not significant because I have to preserve the blood supply. What do you think about this, sir?
First of all, the reduction, anatomical reduction, is needed only as the articular fractures.
Yes.
For post-operative, full range of movement. But in the diaphyseal fractures, we don't need anatomical reduction. We need only the length, alignment, and we don't accept rotation. So we have to do indirect reduction at the diaphyseal fracture, but open reduction for the articular fracture to be sure that you got the anatomical reduction. The less invasive technique is very difficult to do, but they have special courses. So if you don't master this technique, please don't use this technique, because you will got very long hours in your operation, which allow infection, non-union, and delayed union, something like that. So do what you know, and less distraction or obliging the soft tissue and the blood supply. You must preserve as much as you can, because you know, Professor, that we don't need the fracture, and we don't accept to treat patients by WhatsApp. At what we was going in this on this day. Please look to this picture, X-ray, and tell me what's the treatment. This is very wrong. You must look for the patient, examine the patient, and to avoid many complications, that you don't respect the soft tissue before the bones. The bone fracture can still wait 1, 2, 3 weeks, no problem. But first of all, you have to be care about the soft tissue.
Yes, sir. Some of our trainees, sir, are asking me about the MEBO technique and the internal fixators.
Yes, the MEBO technique, I just tell you, that have a special course to be trained, like the basic course, advanced course. Also, we have the MEBO technique. This is will be trained for about 4 days in our courses, workshops, to know very well the applying this difficult technique. But if you master this technique, you will get very good results. But because it is very friendly with the soft tissue care.
Yes, sir. We have a question, sir, from one of our attendees. What about intramedullary fixation with extramedullary fixation in the same time? For example, cerclage and nailing.
You can do what you know, because you know every patient have a special situation. Intramedullary nailing was very friendly, less destructive to the soft tissue, and very easy to get union, and the patient return to his work very early. And in some situations where there is a multifragmentary fracture, you can use cerclage. Also with the medullary nailing, always use fixator. Why not? This give you a very good result.
Yes, sir. Do you prefer, sir, augmented external and internal fixation or cerclage wiring plus intramedullary nailing? Because some are saying that when I'm using cerclage, I'm destroying both periosteal and endosteal circulation.
Yes. As I told you, sir, that every situation for every patient.
For every patient. Yes, sir.
We prefer to use internal with external supplementary fixation in some situations, not all the situations.
Yes, sir. Dr. Srinivas, do you have any other questions, sir, to Professor Elzohairy?
Thank you very much, sir, for the excellent talk. It was very comprehensive and informative. Unfortunately, Dr. Bhattacharya had to leave because he had an emergency, attend an emergency. So he sends his apologies for this. I just wanted to ask about the O-arm, sir. Do you need a special table to use the O-arm as well, or
this is 3D, three-dimensional. It doesn't need special orthopedic table. It's very advanced now and used in most of the developed countries in Europe and USA. But unfortunately, they use this apparatus in neurosurgery.
Yes.
And Professor Shyam was the first one to use this apparatus, and he discovered his fault that he treats many upper tibial plateau fractures, that's medial and lateral only parts fracture, and he forget to examine the posterior part, and he got many failures of this classification, and now he obliged for this and doing now his best to write a new classification that will be 8 columns in this area, and this will give a big chance for the doctor and the patient to get best results.
Yes. As you said, sir, Professor Masato Tanaka from Japan, he's a spine surgeon, is using the O-arm routinely in his spine operations. He's a spine surgeon. And as you have said, sir, exactly, it's more applicable for the spine surgeons.
Spine surgeons, yes. But why my goal, my presentation today changes of concept? Because this lecture, I am sure that will be changed by the using this apparatus. So I think that next meeting or something like that, I will change all what I said today.
It must be saving a lot of time for the trauma surgeons as well, isn't it? Because if you have the AP and lateral images in one shot, it saves a lot of time and effort when doing the cases.
Yes.
So we have also to learn the new generation doctors what's now the evolution in the world of orthopedic operations and orthopedic techniques.
Yes. I think we have no more questions. Professor Alaa, thank you so much, sir.
Thank you, Professor Ashok.
Thank you so much, sir. It was an honor for us, sir.
And I thank all our colleagues that join us today.
Thank you so much, sir. Finally, I would like to thank our Indian colleague, Professor Rajarshi Bhattacharya from London, from UK. My dear Professor Alaa Elzohairy from Egypt, from Suez Canal University. My dear friend, Dr. Srinivas, for his great effort to complete this course. I would like also to thank OrthoTV for streaming the presentations of our course live on their video channel. Many thanks to Eva Company, and see you, inshallah, on next Friday with 2 presentations from India and Egypt about wrist trauma and wrist arthroscopy. Thank you so much. See you, inshallah, next Friday. Thank you so much. Dr. Srinivas.
Thank you, sir.
Thank you so much, sir.
Thank you.
It was an honor. Thank you. See you, sir. Thank you so much.